Welcome to the Chapter 11 lecture for microbiology. Chapter 11 is the starting chapter of our third unit in the class, which is going to be really all about the immune system and how the body fights infection. But before we get there, in Chapter 11, we're going to first talk about how microbes get into the body and cause infections. So before we get into sort of the bad guy side of bacteria, I do always like to remind you guys that microbes are not always bad. In fact, there are a lot of microbes, probably more microbes that are good for us than there are those that are bad for us. But it's the ones that are bad for us that we tend to focus all of our research attention on. So as a human, we are a host for pathogens, but we're also a host for lots of commensal and mutualistic bacteria that actually help to safeguard us from pathogens through microbial antagonism. That's what this cartoon is depicting here, that these sort of orange bacteria are our normal microflora that set up residency and help to train our immune cells and maybe make antibiotics of their own that help to fend off potential invaders, pathogens that want to colonize. So this video here, I'm not going to play it in this recording, but it's a TED Ed video, and if you just Google or go to YouTube and type in Invisible Universe of Human Microbiome, you can find it and rewatch it. But it's a great little explanation, animation of all the good that our microbes do for us. So there's actually a huge research project called the Human Microbiome Project, where scientists are trying to sort of catalog and categorize what are the normal flora in different parts of the body, and are there certain combinations that signify disease states or contribute to disease states. Maybe certain chronic diseases like cardiovascular disease, diabetes, obesity, all of them are thought to be related to microbes, particularly our gut microbiomes. And so hopefully this project will reveal more information about how our microbes contribute to our overall health. So the human microbiome is acquired at birth. The fetus is sterile inside the sac, the amniotic sac full of amniotic fluid. There's no bacteria in there. They're not exposed to any bacteria until they are born. So when they're coming through the vaginal canal, they pick up a lot of vaginal microbes that colonize their gut. If they're born via C-section, they end up with a different population of gut microbes because they end up with more microbes that are similar to those that are found on the skin. Because they're handled by people's hands and they didn't come through a vagina. Also, breastfeeding and bottle feeding has been shown, formula feeding has been shown to differentiate the types of gut microbes. Breast milk, actually a third of the components of breast milk are short chain polysaccharides that are not digestible by humans. Our human cells don't use them, but our gut bacteria do. And they're thought to help select for the optimal gut bacteria. Now that we know about them and have discovered them, potentially we'll start adding them to formula recipes to make them even more equivalent to breast milk. But what is unclear still is how these differences actually affect the overall health of the baby. So some things we do know, some correlations. Babies that are born via C-section versus vaginal birth tend to have a higher risk for allergies. And same thing with those that are formula fed versus breastfed. But whether correlation doesn't always equal causation, so we can't be certain yet until we do longitudinal studies to look at the effects of these different gut microbes in infancy to see if that affects later on, life later on. But what is known is that there are definite differences in the gut microbes of babies that are born differently and fed differently. What this means in the long term, we still don't really know. But definitely want to find out. Okay, so that's how we get our good microbes. Now for the bad guys, the pathogens. these are any microbes that actually cause disease. And again, I guess we can't really distinguish good guys and bad guys in microbiology because there are plenty of normal flora that can actually cause disease if they get into the wrong part of the body or if they just feel like it. So there's not really a black and white line between the good and bad, but we can say that pathogens either qualify as true pathogens or opportunistic pathogens. Now, true pathogens are ones that cause disease in healthy people. These are the ones we typically really truly think of as pathogens. But then there's also opportunistic pathogens, and these are microbes that don't normally cause disease in healthy people with a good immune system, but can cause disease in people who are immunocompromised, particularly problematic for people who have AIDS and are immunocompromised because of a lack of T cells, people who have other autoimmune diseases that affects their, or immunodeficiencies, people who are on chemotherapy and immunosuppressant drugs, all right, would all qualify as people who are prone to some of these opportunistic pathogens. Now, the features of bacteria that contribute to disease are called virulence factors. A microbe's virulence is its ability to cause disease. And to cause disease, it kind of has to go through 3 phases in the host. So it needs to be able to get in. So virulence factors can be surface molecules that help them to adhere to surfaces and enter cells. All right. Virulence, once it's in the host, it needs to be able to cause damage. That's the actual disease. And so virulence factors can also be things like enzymes or toxins or anything that actually damages tissue. And then they also need to have a way to exit. Usually virulence factors are things that contribute to the attaching and the damaging, and usually the host is sort of in charge of the exiting mechanism. And we'll talk about all of these things in the next few slides. So this first step of infection is, of course, becoming established, getting into the host. And so microbes need to have an entry point. So most of our body is covered and protected by the largest organ, the integumentary system, or the integument, the skin and hair and nails. And so microbes can really only get in. There are some that can actually infect the skin itself, but most would have to get in through a breach in the skin, like a cut or a wound. Or they get in through one of the orifices, eyes, mouth, nose, gut, our mucous membranes. So there's a lot of different portals of entry, but we do have at least that first line of defense, the barrier of our skin. So a lot of infections are exogenous, meaning we get the microbes from our environment. Like somebody coughs on us and we breathe in the droplets, or you accidentally eat some food or drink some water that's been contaminated with animal fecal matter. All right, those are things that came from outside our body. There's also such a thing as endogenous infections, and these are, I don't know which is more common, but they're also pretty common. So staph infections. Staphylococcus aureus is found on about 30% of people are just carriers for it. And so if you get a cut and some staph aureus from your skin gets into that wound, it can cause a staph infection. So that basically you gave yourself that infection. That's an endogenous infection. Another great example is urinary tract infections. Most common cause of urinary tract infections is E. coli. That comes from the gastrointestinal system. Basically, getting a little bit of fecal matter into your urethra is the cause of a lot of urinary tract infections. So that would be endogenous. It came from your body. Now, in order to get an infection, it's not enough just to come into contact with a pathogen. You need to come into contact with enough of that pathogen to actually get into your body and start replicating. And for some pathogens, that number can be pretty large, and for some, it can be pretty small. To relate this to the coronavirus right now, there's a lot of studies coming out with different materials and surfaces that coronavirus is detectable on. So coronavirus, I think it was think it was Harvard, a Harvard research study, but don't quote me on that, that tested different surfaces. Basically, sprayed some coronavirus on different surfaces and then tested for hours later to see how long that virus was detectable. And it was detectable on cardboard for 24 hours. I think it was detectable on steel and copper for less time, maybe like 3 hours. I have a terrible memory for numbers, sorry. And I think on plastic for a couple of days. So basically what they were saying was coronavirus, they could test those surfaces and still detect coronavirus. That doesn't mean that the coronavirus is still highly infectious. It doesn't mean that they can detect an infectious amount of coronavirus. So we don't need to panic too much about those findings, but we do also still want to be careful about surfaces we touch because, as we'll see, fomites or inanimate objects are a very common spreader of disease. But at the same time, it's not just about touching a surface that contains a microbe. It needs to contain enough microbe, and then after you touch that surface, you need to actually touch a portal of entry. All right, so making sure you're washing your hands and not touching your face and your nose and your mouth, all right, and staying away from your mucous membranes will help to protect you from actually getting that pathogen into your body, right? This is just a table of some different pathogens and how many with the minimal infective doses, and these are all fairly small, but so for Staph aureus and Strep pyogenes, which causes strep throat, less than 1,000 colonies, or sorry, less than 1,000 bacteria is enough to cause an infection. But for some of these others, 10 to 50 organisms is enough to cause an infection. And for some that are not on this list, millions might be required to cause an infection if it's not particularly virulent. So it needs to get in, and you need to have a minimum infective dose to actually get in. And for different people, that minimum infective dose might be different depending on your immune system and whatnot. So there's no like hard and fast magic numbers. But once you have enough pathogen get inside a portal of entry, then they have to figure out how to stake a claim and stay and multiply in the body. So they need to be able to adhere. So bacteria and viruses tend to have spike proteins on the surface. Viruses have spike proteins. Bacteria have a glycocalyx or some fimbriae or something sticky on the surface, both of which will allow them to stick to surfaces so that they or bind to specific cell types based on a receptor recognizing their proteins, as we see here with the virus. Larger organisms like worms and even some protozoans may have sort of hooks or barbs or suckers that they use to physically latch on to blood vessels or intestinal wall. But all of these things are necessary for them to establish themselves in the host to stay put. Then once they are in and once they are stuck, they then need to be able to get through the defense system of the body, the innate defense system, really, first of all. So the first, I guess I should say that, so now they've gotten past the first line of defense, the skin and the barriers and the mucus, and they're in. And now they have to get past the second line of defense, our phagocytes and inflammation, right? So there's a couple of different ways they can bypass phagocytes. Some bacteria produce a capsule that's really slimy, and so they can sort of slip out of it when a phagocyte catches up to them and tries to engulf them. They sort of slip out of their capsule and escape. Or otherwise they have a capsule that, just to anthropomorphize here, tastes disgusting to the phagocytes, so they won't engulf them. So they can avoid phagocytosis. So that's an anti-phagocytic thing they can do. They can also kill white blood cells. They can produce chemicals that are leukocidins. Remember, cidal means to kill, homicidal, bactericidal. So something that is leukocidal is deadly to white blood cells, leukocytes. There are a handful of different microbes that have learned a special skill of surviving after phagocytosis. They get eaten by the white blood cell, and then instead of the white blood cell fusing the lysosome and digesting the bacteria somehow blocks that fusion and then lives and replicates happily inside that white blood cell, very sneakily. So those are all some different clever ways that microbes or pathogens have learned to evade this process of phagocytosis, our second line of defense. All right, now that they're in and they have survived our initial defenses, they're going to start doing damage. Now, some initial damage will be caused by the the innate immune response, or the second line of defense, through all the cytokines that phagocytes produce, but also the bacteria itself, or the parasite, protozoan, whatever, might produce its own enzymes that further damage tissues. Usually these enzymes digest cellular tissues or extracellular tissues, so they can make the tissue even more permeable for more bacteria to get in and help the bacteria spread. They can produce enzymes that cause blood clotting or that cause blood thinning. Ebola, hemorrhagic fever, produces a blood, actually it widens the blood vessels, so it doesn't thin the blood, but it actually causes you to internally hemorrhage because of a dilation of the blood vessels. So, and that's the disease, that's the pathology of the disease. So we'll talk about ones in the future that produce toxins that are like neurotoxins. So that's another chemical that can cause damage. And that's on this slide here. Okay, so bacterial toxins are different than enzymes. Enzymes chew up things, they break down things. Toxins usually bind to cellular enzymes or proteins and inhibit them in some way. There's a lot of the toxins that pathogens produce are exotoxins, meaning they secrete them and then they get released into the tissue. So tetanus, for example, produces tetanus toxin. You get a cut, you step on a rusty nail and you get a cut in your foot, and the tetanus bacteria grows in your foot and produces a toxin that actually is neurotropic. It goes to the nervous system and it inhibits nerve cells that contribute to muscle contraction, and it actually causes sustained muscle contraction. Tetanus toxin does. So it goes to the nervous system and spreads throughout the body, throughout the nervous system. Even though the infection is specifically in your foot, the toxin is secreted and it gets spread throughout the body. Endotoxin is specifically referring to lipopolysaccharide, or LPS, and it's a polysaccharide that's found on the inner membrane of gram-negative bacteria, and so when they die inside the body from immune attack and they rip open, they spill their guts out and all this LPS is released into the system. And we've just evolved to automatically recognize LPS or endotoxin as bad, and it automatically kickstarts part of our innate immune system and lots of inflammation, lots of cytokine production, and if there's too much of that, it can actually cause systemic shock. So endotoxin, not so good. All right, so this shock, this septic shock that can occur from endotoxin is very dangerous, because what's so difficult about it is it's not the bacteria so much that is damaging you at this point. It's a really strong immune response. So a common theme that we talk about in immunology is the immune system is there to protect us, but sometimes it goes haywire and ends up damaging us. And in a lot of cases with like sepsis, bloodborne infections, when a bacteria gets into the blood and you have this massive release of cytokines throughout the body, then these cytokines start damaging different organs. They can damage the lungs, they can damage the kidneys, and then you start to end up with organ failure, and ultimately death because your organs are failing because of all these cytokines your immune system is making. This was a big problem in the 1918 flu pandemic. The cohort of people who died the most deaths from the 1918 flu were in the like 20 to 45-year-old age range, which is atypical for flu, which usually affects the very young and the very old. And it's thought, and scientists who've actually like unearthed 1918 flu and studied it in labs, that it was so bad in that age group because it triggered one of these cytokine storms. That basically it triggered a massive inflammation in the lungs that damaged the lung. It wasn't the virus itself, and that's what led to death. And we're starting to see that here in the US with this current coronavirus. Being a new pathogen, it's new, the immune system, it's totally new to the immune system. And in young people, I mean, most of the people who die from this virus are over 60 and have other comorbidities, but there are young people who are dying, and it's basically from massive inflammation. And the sad thing about this, the difficult thing about this sort of cytokine storm, is we don't have a good way to treat this medically. Suppressing the immune system is not the answer because it's needed to fight the infection. If you try to suppress the immune system, then the infection takes over. So one area of immunology that's really interesting and being studied is how do we help to control an out-of-control immune system that is killing someone. But yeah, that's one of the ways bacteria and viruses can cause disease is by actually overstimulating the immune system, and then the immune system actually damages your body. All right, another way that microbes can cause disease is through physical obstruction. My favorite example is elephantiasis. This is a disease, the condition is often known as elephantiasis because it causes very large swelling, usually of the limbs or of the genitals. And it's due to a backup or a blockage of the lymphatic vessels by a worm called a filarial worm. So the medical name for this disease is lymphatic filariasis. These little filarial worms basically congregate in the lymphatic vessels and physically block it. And the lymph is responsible for draining fluid from your tissues. So if it's blocked, the fluid has nowhere to go, and it just stays in your tissues and builds up, and you get this swelling. And it's very difficult to treat because you can't really do surgery on the vessels at that point to pull out the worms. They get damaged. It's a mess. There are medications you can take to kill the worms, but they may still stay blocked in that lymphatic vessel. There we go. Okay. Some other terms referring to infections. You could have an infection that's localized in a specific area. So, like I said, if you step on a nail and you get a staph infection or something, or a tetanus infection in your foot. A systemic infection is one that spreads throughout the body. So this can happen very unpredictably. People can get systemic infections from a paper cut, basically. I've read stories of people who nicked their finger on like a rose thorn, or on like a piece of wood, like a splinter, that then ended up turning into sepsis. The more common systemic infections come from like a kidney infection, urinary tract infection, pneumonia, things that are more internal infections that then are untreated and spread throughout the body. But basically a systemic infection happens when a local infection, when bacteria from a local infection escapes and gets into the blood and starts replicating there. Skipping down to the terms primary and secondary infection. A primary infection is the first disease that you get. And because your immune system is busy fighting this primary infection, it leaves the body weaker and often susceptible to getting additional infections on top of that, which we call secondary infections. This is very common with flu and respiratory viruses. You get a virus and and your lungs are compromised, your respiratory system's compromised, your immune cells are fighting really hard, and then a bacteria moves in on top of it. So you may have flu and bacterial pneumonia. So sometimes you'll see doctors prescribing antibiotics for people with viral infections. Remember, viruses are not treatable with antibiotics, but what they might be doing is trying to prevent secondary infections, particularly in people who are very susceptible to secondary infections because they have other comorbidities. So that's another thing to consider, secondary infections. Acute and chronic. Acute means that it is usually severe and the symptoms came on fast, and usually it resolves itself somewhat fast. Chronic infection is one that lasts for several months. I think 3 months is the definition for chronic. Resistant infections tend to be chronic. There are some infections that are naturally long-lasting, like tuberculosis, particularly resistant to treatment. You can get antibiotics for tuberculosis, but the course of antibiotics is like 6 months to a year. It takes that long to treat. So that would be a type of chronic infection. So when diagnosing infection, you go to the doctor and they're going to look for signs and symptoms of disease, and that's going to help them come up with a diagnosis. So just a quick distinction between a sign and a symptom. A sign is something that doctors look for, or nurses. Your practitioner examining you is going to look for signs. These are objectable, measurable evidence of not normalness of the body. So a rash or swelling or fever or weight gain or weight loss, all of the tachycardia, increased heart rate, oxygenation level, those are all things that can be checked, can be measured, and recorded on a chart. A symptom is something that is subjectively experienced by the patient. Pain is classic symptom. Nausea is a symptom. Those are things that you feel, but you can't measure. And you could ask a patient, to rate their pain on a scale of 1 to 10, but it would be that the same amount of pain might be measured differently by different patients. So it's very subjective. Okay, so some classic signs and symptoms of infection: fever as a result of the innate immune system producing cytokines like pyrogens, pain, swelling, edema is the medical word for swelling. All of those things are related to cytokine production and the second line of defense. An abscess is basically like a very hard sort of swollen area. I'm referring to my lymph node here because I often talk about my daughter. When she was 3, she got an abscessed lymph node. Her cervical lymph node here just got infected with, I can't remember if it was staph or strep. I think it was staph. And it became abscessed. So just like a mass of bacteria and white blood cells, just full of, that's what it was full of. So usually abscesses have to be lanced and drained because the infection is so dense that it's hard to penetrate with just like oral antibiotics. Lymphedema, swelling of the lymph nodes, not to quite that extent that my daughter had it, but a mild swelling of the lymph nodes is often a sign of infection. Your lymph nodes, remember, they're sort of hothouses of lymphocytes, B cells and T cells. And so if you have like a respiratory infection, the lymphatics will drain fluid and bacteria or viruses to the cervical lymph nodes here in your neck, and they'll start mounting an immune response. So they get a little swollen when that happens. If you had an infection in your arm, all right, then your axillary lymph nodes in your armpits would get swollen. So it's the draining lymph nodes that tend to swell. Infection can also be detected by a simple blood test. A CBC, a complete blood count, looks at the different types of cells in your blood, including your white blood cells. So on this CBC report here, WBC stands for white blood cells, which we call leukocytosis, an increase of white blood cells. And that's a sign of infection. It can also be a sign of leukemia, of white blood cell cancer. But the number ranges, I think, are different, and also there's different symptoms. So And there's different tests they would do to continue to differentiate that diagnosis. But a high white blood cell count is often indicative of an infection. They can also test the blood for bacteria, for bacterial growth, to check for septicemia. The problem is that some people may have an infection and just not have any symptoms of it. So an asymptomatic or subclinical patient would not feel sick, but actually be carrying around a pathogen and potentially spreading it to other people. This is really common with a lot of sexually transmitted diseases, both gonorrhea and chlamydia. About 50% or so of cases are asymptomatic, so people can have it and not know it and be spreading it to others. Also, sometimes people with a subclinical or asymptomatic infection may later experience symptoms. So, for example, HIV is often asymptomatic until it's not. So, not to freak you out and make you think, oh my God, you have a disease and you're just asymptomatic for it, but it is something to consider as we also talk about disease transmission. So disease, the last step of sort of causing disease is getting out of the host. A successful pathogen, if it infects a host and then kills that host without moving on, it's going to die with its host. So it really needs to make sure it has a way to exit the host and find new hosts so it can keep replicating. And so every different infectious organism will have a different portal of exit. Respiratory organisms tend to exit through respiratory secretions, snot, mucus, coughing, sneezing, that kind of thing. Bloodborne pathogens can be transmitted through needles, like sharing of needles, but also through insect bites. There are a lot of gastrointestinal organisms that are transmitted through fecal matter that gets on people's hands when they don't wash their hands after going to the bathroom and then touching things. The urine is not a particularly common portal of exit, but can be for some organisms. And then skin lesions like chickenpox and measles that cause lesions. The lesions themselves actually are shedding virus and can be a mechanism of spreading disease. So it's really important for each disease to understand the portal of exit and the mode of transmission so that you can keep other people safe and protected. So if you have shingles, for example, the shingles rash is actively shedding varicella zoster virus, which could give someone chickenpox if they haven't had it and they haven't been vaccinated. But keeping that patch of shingles covered, not touching it, maybe keeping it sealed off, can help to protect you from spreading it to others, for example. Same thing, if it's a respiratory pathogen, covering your mouth when you sneeze or cough, or nowadays with coronavirus, if somebody is actually infected, wearing a mask to prevent their secretions from getting onto other people and surfaces can help to prevent transmission. So some microbes will stick around for a long time, and that's very convenient for them. A lot of times they don't kill their host or cause severe disease right away. Like, for example, we were just talking about shingles as an example. Shingles is the varicella zoster virus. It causes chickenpox and shingles. And the initial disease that it causes is chickenpox. That goes away, but it doesn't really go away. The virus, actually, it's a type of herpes. Varicella zoster is in the herpes virus family. And all herpes viruses, they infect the skin, and then they cause some kind of a skin lesion to form, but then the skin lesion goes away, it heals up, and the virus actually infects nerves and travels down the nerve all the way to the nerve root ganglion in the spinal cord, where it hangs out and lays dormant for years, decades, maybe forever. Some people may not have a reactivation, but eventually they might have a reactivation of that virus. In the case of varicella zoster, chickenpox, when it reactivates, the virus then goes down the nerve root back to the skin and ends up causing shingles, a different disease, but also of the skin. Herpes simplex, which causes cold sores and genital ulcers, is also in this family and does the same thing. Another thing that can happen is you can have a sort of long-term side effect of an infection, and that's called a sequelae. So a classic sequelae is rheumatic fever, which can be a complication of strep throat if it's untreated. So strep throat, very common infection in kids, even in some adults, causes pharyngitis, inflammation of the throat, really sore throat. And you take antibiotics to get better, but maybe you decide, I don't want to take antibiotics. I don't want to contribute to the problem of antibiotic resistance. I'm sure I'll be fine. Strep, it's just strep, I'll get better on my own. All right. Well, what can happen in that situation is the strep might get better on its own, but it may also elicit an immune response that goes a little haywire. So strep has some proteins that happen to mimic or look very similar to cardiac proteins in the heart. And so when we make an antibody response towards the strep bacteria, some of those antibodies sometimes end up attacking the heart tissue. And then you end up with rheumatic fever, which is sort of can cause permanent heart damage. So you don't want to leave strep throat untreated because you don't want to end up with this particularly serious sequelae. Polio virus, very classic example. I think it, again, don't quote me on numbers here. I think it was something like 30% of people who got polio ended up with paralysis, severe paralysis, usually in the lower body, as a sequelae of this disease. So the disease itself was like, it did cause some muscle paralysis, which could cause respiratory problems, and people needed an iron lung to help them breathe, which is sort of like a old-fashioned ventilator. And then they got over that acute phase, and many of them recovered and were fine, but a lot of them recovered and were not fine. They ended up with long-term paralysis, which is a sequelae of polio. All right, so in an infection, the microbe goes through a series of phases, kind of like we see with growth of bacteria in a culture. So initially in the culture, we have that lag time. In an infection, in a host, we call that the incubation period. So during the incubation period, the microbe is not really, it's not multiplying. It's just kind of trying to find its way through the host to the right tissue. It's attaching itself, getting into cells, evading phagocytes, getting established, all right? Then, once it's in and the secondary response, the second line of defense kicks in, your innate immune system sees that it's there, it starts releasing all these cytokines. And those cytokines kind of give you the same crappy symptoms like at the start of any infection. So no matter what infection you have, a lot of times at the beginning, you have fever, you're fatigued, you're sore, you feel crappy, right? And all of those sort of crappy feelings that are kind of nondescript. We call that the prodromal phase. And that's really more caused by your immune system responding to the pathogen. Then there's the period of invasion, and this is when the pathogen's really multiplying, starting to cause tissue damage. You get more specific symptoms, a cough, a runny nose, ears hurt, whatever, your stomach hurts. That is the when you're going to get those specific symptoms of the infection. But also, hopefully, your immune system is kicking in, your second line of defense, the innate immune system, but also the adaptive immune response is starting to kick in, and then you hopefully kick that infection, and you start killing off those microbes. Slowly but surely they start dying and you start feeling better. And during this period, we call this the convalescent period. Usually your symptoms start to disappear, but it doesn't necessarily mean that you're free of microbes yet. So we'll talk about this convalescent period being a time where people can still spread disease and not realize it. So disease can come from many sources. Where do I want to put my face? We're going to go right here. we call a source of a pathogen a reservoir. It's the primary habitat for a pathogen. So some pathogens live in living things only. Some of them live in non-living things. So like cholera, for example, is a free-living bacteria that you can find in a lot of water sources, untreated water sources. And so you drink unclean water, cholera gets inside you and causes an infection. So there's a lot of worms that live in soil that you can get even just from walking barefoot in the soil. So those would be non-living reservoirs. Living reservoirs are other people or animals or insects that can transmit disease. So there are some diseases that can be transmitted directly from animals to people. Flu being one. Flu is particularly promiscuous. It can jump species. But for the most part, there's not a whole lot of diseases you can catch from your pets, like cats or dogs or horses or birds. You can get diseases that are transmitted by biting insects, ticks and mosquitoes being the two most common ones. And then, of course, you can get diseases from other people. You can get them from people who are asymptomatic. We talked about sexually transmitted diseases being very frequently asymptomatic, so people can transmit them without realizing it. People who are in that incubation stage of infection, they've been exposed, they are carrying around the pathogen, but they're not feeling sick yet, they don't have any symptoms. They can spread it, and that's definitely happening right now with the coronavirus. And then there's also the people on the flip side of infection. They had it and they're better, and then they can spread it. I think there's fewer of those spreading this infection because with coronavirus, people who are testing positive are really quarantined. But there might be people who have mild symptoms, don't test positive, and then when they feel better, they go back out into society. They may be convalescing and still transmitting this virus. You can also have people who are chronic carriers. So people who are sort of chronically asymptomatic, they don't have any symptoms, that it's not causing any disease, they just carry a microbe that can be a pathogen, and it's just a normal microbe for them. So the classic tale here is of Typhoid Mary. She was a maid in, I think, upstate New York, or maybe it was like Massachusetts or Connecticut, somewhere in New England back in the early 1900s. And she like worked for a family, and everyone in the family came down with typhoid fever. So she lost, they all died, and she moved on to another family. They all got typhoid fever. It became this pattern, and when the public health came in and investigated, they realized that she was the common link. So they tested her and found out that she was a carrier of Salmonella typhi. It didn't make her sick, but she did carry it in her intestinal flora, meaning that when she was preparing food, her hands were not truly clean, and she was preparing food and serving it to the house members, and then they were eating her fecal matter, essentially. They tried to quarantine her for a couple of years. They basically imprisoned her. And then someone argued on her behalf that it was unconstitutional. They let her out, but they said, you just cannot work in the food industry because you're a carrier for this disease, you're spreading this disease. We don't want to see you working in the food industry. She's like, okay, I won't. But she was a woman in the early 1900s. There were not a lot of jobs that she was able to do, that she could be hired to do, or that she was trained to do. She knew how to cook. So she found herself back in a kitchen at a hotel, and lo and behold, there was a typhoid outbreak at this hotel. Public health came in, and who did they find in the kitchen but Typhoid Mary? So let's all try not to be Typhoid Marys. Yeah, and all right, okay, so then the last one here are the passive carriers, and these are like classically we think of like healthcare staff in healthcare facilities that are treating multiple patients, and they may go in and treat one patient with an infectious disease, and then if they don't change their PPE or follow the proper procedures, they may inadvertently end up transferring some infectious agent to another patient without necessarily getting it themselves, but they transfer it on their hands or something to another patient. So it's also a really important reason to follow good protective and asterile technique in healthcare so that we don't act as passive carriers. So infectious diseases do tend to be transmissible from person to person. We say that they are communicable or contagious. But contagious is a relative term. So some things are not very contagious, some things are very contagious. So the epidemiological measurement, the number that measures that we use to score how contagious a virus is called R naught, and it's written R with a little 0 subscript. And so the R naught sort of represents the number of people on average that an infected person will infect. So for Ebola, it has an R naught of 2, meaning that one person with Ebola on average will infect 2 other individuals. All right, versus measles, which has an R naught of anywhere from 12 to 18. It's super, super contagious. One infected person can infect 15 other people easily. All right, so the current coronavirus, just for your reference, is somewhere between Ebola and HIV. It's still a moving target, but we think it has an R naught, a contagious factor, of around maybe somewhere between 1 and 3, I think is where the numbers are at. So usually averaging about 2. So not highly contagious, but because of the respiratory nature of it and because of its newness and hardly anyone is immune to it, it's still spreading very quickly. If every person who's infected infects 2 people, and then those 2 people infect 2 more people, and then those 4 people infect 8 more, so you can see that the numbers just keep doubling and doubling and can grow exponentially very quickly. So a small R naught can still cause a very rapid rise in an infection. This is just a cool chart that kind of graphs the deadliness on the y-axis and the contagiousness on the x-axis. So you can see measles here is very contagious, all right, not super deadly, but very contagious. Versus over here, we've got Ebola, which is super deadly, but not very contagious. Trying to see what year this is from. I think this is a little bit dated. I think Ebola's numbers, deadliness-wise, has gone down just a little bit. But for some reference with the current coronavirus, so we've got seasonal flu right here. All right, has a contagiousness between 2 and 3. All right, coronavirus is probably about the same in terms of contagiousness, a little bit more, and also more deadly. So about 2% right now is where it's averaging. So it's looking a little bit more like where this SARS is up here. So the original SARS from 2003 was more deadly than this SARS, but not quite as contagious, and we controlled it a lot faster. But somewhere in this area, if you can see my arrow, is my cursor, and I'm trying to indicate the area where our current coronavirus 2019 COVID-19 lies. Oh, and then I have this image for you here, just showing you in a different way. So Ebola has an R naught, it's of 1 to 5 to 2.5, and coronavirus is about the same as that, just not nearly as deadly as Ebola. So it's a little bit less to maybe about as contagious as influenza, just far more deadly. All right, so the way that people can give disease to each other is through direct contact, so actual physical contact between 2 people, shaking hands, kissing, if you sneeze in somebody's face. So close physical contact can result in transmission. Indirect transmission, though, also happens through what we call fomites, inanimate objects that transmit disease. A very classic fomite are door handles. You cough or sneeze in your hand and then you touch a door handle and everyone touches that door handle. Or you go to the bathroom and you don't wash your hands and then you touch the door handle and everyone else touches the door handle. So fomites are also of concern right now with the current COVID-19 pandemic. Vector transmission is another way that we can spread disease between people. so it requires biting insects to be present. So we're fairly fortunate up here in the North Country, northern New York. We don't have a lot of mosquitoes, and they are only alive and around for a short window of the year, and they don't tend to carry disease, though some of them do carry encephalitis viruses, but not like malaria. We'll never, well, I shouldn't say never. I'm going to say we'll never have malaria up here because it's not warm enough, but with global warming, you just never know. Some infections are acquired in a hospital, and this is such a common phenomenon that it has its own name. So a nosocomial infection is an infection that's acquired during a stay in a hospital. The most common types of nosocomial infections are urinary tract infections, which are from being catheterized. So normally you don't have a tube going up into your urethra that's connected to the outside world, and it can be a source of infection. Surgical wounds becoming infected. Again, you're opening up the body and ruining that first line of defense barrier. Respiratory infections, which can come from respirators, and being intubated is to help you breathe, but it can also introduce bacteria into the respiratory tract. Skin infections, blood infections, septicemia as a complication from some other infection. So because of that, because infections spread so easily and quickly in hospitals, because it's a hot spot where you have people who are sick with infectious disease, and then you also have a bunch of people usually who are immunocompromised because they've had surgery or transplants or they're having chemotherapy or whatever. And so it can become this real hotspot for disease. And you also have staff potentially going from room to room to room that can act as passive carriers. So it's really important in healthcare to use universal precautions and basically always assume that everyone and everything is infectious. So making sure you wear proper PPE, personal protective equipment, to both protect yourself and your patients. Make sure that you dispose of waste properly. Make sure all your tools are sterilized, that you're using clean, sterilized tools, and that you're washing your hands, lots and lots of hand washing. And if possible, to get vaccinated, get your flu shot, make sure you're up to date on all of your vaccines so that you don't get sick with any transmissible diseases that you can prevent. Now, if we are trying to determine what organism is causing a disease, then we can do some tests. So the tests that we do stem from the original diagnostic criteria that Koch came up with in the late 1800s. Koch's postulates are what they're called. And so it's basically a series of steps to prove that something is the causative agent of disease. So not just correlation, but to identify causation. So if you have a bunch of sheep and they all get sick and die, and you cut them open and you find that they all have the same bacteria in them, that's great. That's a correlation. But if you want to prove that that bacteria causes disease, you need to take that bacteria, culture it, inject it into another animal, see that it gets the same disease and dies, open it up, and find that same bacteria. So only by going through these steps can you prove that it's actually that bacteria that's causing that disease. So we have done that in labs to identify causative agents. We can't do that always in infectious disease because not all organisms are culturable, or a sheep pathogen may or may not cause disease in a mouse, in a laboratory animal. So these steps don't always work for identifying disease, but can be very helpful. All right, so the medical professionals whose job it is to study and track disease are epidemiologists. So epidemiologists are sort of, I think of them as like disease detectives, and they keep track of the spread of disease and help to control the spread of disease. And basically they're like statisticians. So it's a lot of math, not actually any medical treatment. So there are a lot of diseases that are what we call reportable to the health department, to the CDC, because there are epidemiologists studying those diseases and keeping track of them. Flu, Certainly coronavirus. HIV, sexually transmitted diseases, all right? Common cold, no. But most other infectious diseases, yes, are reportable. So that we can, and cancer is reportable too. That's how we get all these statistics. So the two biggest, most important statistics for epidemiologists are incidence and prevalence. Incidence, the key word there is new. It's the number of new cases over a certain period of time. So there's tons of graphs out there right now for COVID-19, the number of new cases per day in different country. All right, and that tells us, incidence really tells us how fast that disease is spreading. And so it's sort of a rate. It's the rate of disease. Prevalence tells us how many total people are infected. And so it gives us more an idea of like what is the total burden of that disease. So this is just a little mnemonic that I found that I like. Prevalence has AL in it, so think it means all the cases in the total population. And incidence has an N for new. It's the number of new cases. Those are sort of the key words there. So just to do an example problem with you, if this graph here represents a 4th grade class with 20 students, and each arrow represents a sick student in the period of time that they're sick for over a 3-month period, January, February, March. All right, we can ask a question like, what is the prevalence of colds during the month of February? So that's going to be all the cases that occurred in February. There were 1, 2, 3, 4, 5, 6 arrows, 6 cases that occurred at some point in February. So that would be 6 out of 20 students. So the prevalence was 30%, or 6 out of 20. The incidence in February, though, is going to be the number of new cases in the population at risk. So the number of new cases, the ones that started in February, were 1, 2, 3, 4. So there were only 4 new cases in February. But the denominator here is not the total population, is not all 20 kids. It's only the kids that were not already sick. And there were 2 kids that were already sick at the start of February. So the incidence would be 4 divided by 18, because 2 of those kids we don't count because they're not susceptible. So an incidence of 4 out of 18 or 22 out of 100 would be another way to convert that ratio. All right, these are just some tables from, or some graphs from the book looking at differences in how we chart incidence. Incidence, usually you're going to see a period of time, all right, number of cases over periods of time, whereas prevalence, you're often looking at the burden of disease in different groups, like different age groups or different genders or races or something like that. All right, so another set of data that's really important for epidemiologists is mortality and morbidity, and certainly something that we're looking at with COVID-19. So the morbidity rate is the total number of people that get sick versus the mortality rate, what number or percentage of people die from the disease. And there are some diseases like rabies has a very high mortality rate, like 100% of people who get rabies die. And some diseases just have a very high morbidity rate, like a cold. Lots of people get a cold, but they don't necessarily die. And then there's everything in between. So for example, this graph on the right here is showing you AIDS from HIV infections from 1985 to 2004. All right, ignore the green line for now, that's looking at money. But in blue, we're looking, or sorry, in red, we're looking at the number of cases of people who have AIDS. It went up, and then we started getting good drugs to treat it, so the number of cases went down. We also saw, so the morbidity went down, but we also saw the mortality go down. All right, so fewer people sick, but also fewer people dying. So when we have, so epidemiologists, the main thing they study are disease outbreaks or epidemics. And epidemics start with someone that is the first case. We call them the index case, or sometimes they're known as patient 0. And it's not necessarily the first case of the disease. It can be someone who was asymptomatic or the first death might be the first patient, but then we realize that patient actually got the disease from someone who was not as sick and didn't go to the doctor. So anyway, there's different types of outbreaks. An outbreak, I'm going to move my face up here, can be endemic, where it is sort of localized to a specific region. So malaria, for example, is endemic. It's transmitted by a mosquito that only lives in certain ranges, certain tropical zones. And so malaria kind of stays put in specific regions because of its insect vector. Sporadic outbreaks are ones that just kind of, you get a random case here and there. And a classic example of that in the US is rabies. Rabies is not very common in the US, but it's everywhere. There are rabid animals that carry rabies. There are reservoirs of rabies all over the United States. But cases in people only crop up once in a while all over the place sporadically because of people getting bit by rabid animals. An epidemic is basically any time you have a cluster of cases that's more than the norm. All right, so notice with a sporadic occurrence like rabies, you have a case here, a case there, a case here, a case there, all over the place. But in an epidemic, you might have 3 or 5 cases in one city. So the number is not a hard and defined number. It's not like 3 cases makes an epidemic. It depends on the disease and what the normal number of cases is. So for measles, where 0 cases is often the norm, then 3 cases can be defined as an epidemic. Whereas for flu, if 100 cases is the norm and then 1 year you get 1,000, then that would be an epidemic. A pandemic is when a disease spreads globally all over the world. And of course, that's what we have right now with COVID-19. It started off as an epidemic in China, but it spread rapidly across multiple countries, all the continents. It's almost to all countries now, probably isn't all countries. So it is truly, truly a pandemic now. All right, so epidemics can have different sort of trajectories. The 3 different types of epidemics that we were going to see in lab but did not get a chance to do are point source, common source, and propagated epidemics. So a point source epidemic is a classic example of this is food poisoning. So like let's say you go, there's a local restaurant with a salad bar and their lettuce at the salad bar is contaminated. So somebody who went to the restaurant January 15th maybe ate some salad and got sick, and then the next day they didn't change out the lettuce and that lettuce was super contaminated. So everyone who ate there that day got really sick, and then maybe a couple of those people who ate there that day didn't get sick until the 17th. But then it starts to peter off because they were all exposed to this food on sort of one day, this one batch of lettuce that was contaminated, and they all got sick over a period of a few days, but then the cases dwindled down. So it's not spreading. This is not a communicable disease that's spreading from person to person. It's just everyone ate from the same source. That's point source. You could also have a common source epidemic. So like if we go back to that example of the lettuce, let's say the lettuce, it's not the lettuce that's contaminated, but or maybe the lettuce, the whole stock of lettuce is contaminated. So even when they keep refilling the lettuce every day, they keep refilling it with contaminated stuff. So basically every day a set number of people goes in, eats the lettuce, and gets sick. So you get sort of a more steady state of cases in that scenario. But what we see with communicable diseases, ones that are spread person to person, is we get this exponential curve. Cases are doubling over a period of time. We call this a propagated epidemic. So when you get a curve like that, where it's going up exponentially, we know that it's communicable, it's contagious, and that's when we need to take it seriously. And of course, that brings us to the current outbreak of COVID-19. So today is March 28th. That is when this is the day that this data is from. There are currently 640,000 cases of COVID-19 around the globe. The US is number 1, which is something we usually like to be, but not in this case. 115,000 cases in the US. Italy is actually top of the charts in terms of death, but we are top in terms of number of cases, and we are steadily increasing still. So social distancing, flattening the curve is still really important. Some other interesting data, this is from March 26th, it looks like, oops, is these charts here. So the one on the left is showing us the number of confirmed cases per country, so this is a couple days old, versus the number of deaths in each country. So you can see, although the US has the most cases, we do not have the most deaths. We actually have a fairly low death rate of 1.4%, versus Italy, which did not flatten the curve, had a huge peak, and has a totally overwhelmed healthcare system, has a massive death rate. The death rate currently there is 10%. 10% of people with coronavirus are dying. Due to a lack of healthcare resources, a lack of availability of treatment, people are being turned away who need ventilators because they just don't have enough for everybody. And that's what we're trying to prevent from happening here in the US, though it doesn't look that promising because our number of cases are rising exponentially still. We're mirroring Italy's cases. If we look at these numbers a different way, if we look at the deaths by sort of per capita number of people in the country, so Switzerland actually has the most cases per millions of people. So although Switzerland is down here with only 11,000 cases, their population is very small. So 11,000 is a fairly large percentage, is a larger percentage of their population than our 80,000 cases in the US. So Switzerland has a lot of the population is actually infected. But same thing with Italy, as we can see here, versus US. We have such a huge population that our large numbers are actually still a small percentage of our population. And same thing if we look at deaths. Italy's are just huge no matter which way you look at it. They have the most deaths per capita, followed by Spain and Iran. Europe is getting hit really hard right now. We're going to see these numbers climbing in other European countries as well. USA is still down here at 4 deaths per million, but again, we're still at the beginning of our curve, so this could go any which way. I also really like these graphs here. The top one is looking at the confirmed deaths in 6 different countries versus daily confirmed new cases in these countries. And the final date on here is March 28th, which is the day I'm filming this. Italy having the most deaths up here, but if we look down here, it does not have the most cases, or the most new cases. So their cases are starting to fall off and plateau a little bit. Whereas Spain's number of new cases is rapidly increasing each day. The US, if you look at our line, it's the steepest. We are rapidly growing in numbers of cases every day, and part of that is due to availability of testing becoming better, and so we probably have had these cases all along, but we're just now identifying them at an alarming rate. Our death rate, all right, is lower than Spain and Italy, but if you look at the slope of these curves, we're pretty much on par with Italy. If we don't slow this down and if we don't flatten the curve, it's just going to keep going up and up and up, and we're going to have a lot of deaths. So this flattening the curve is really important. Maintaining social distancing doesn't necessarily mean that we won't get COVID-19. So we do have to accept that a lot of people, even if we flatten the curve, most people are still going to get this disease. But if we flatten the curve, we can better assure that people who get the disease and who have serious consequences can get health care, can get medical treatment for it. Whereas if we don't flatten the curve, we'll end up like Italy, where they are literally saying if you're older than 70, don't even bother coming to the hospital because we won't treat you. And where they're taking patients who are on ventilators and like basically taking the ventilator away from them and giving it to someone else who they think has a better chance to live. It's super traumatizing for a lot of the doctors and healthcare providers who have to make these difficult choices of who to provide care to. In developed countries, that's not something we usually have to do. But in emergency situations like we have with an uncontrolled outbreak, of COVID-19, that's what will happen. So if we take these protective measures and we hunker down and we keep doing this online learning, and we wash our hands and we don't go to bars and like weddings and parties, and we just keep ourselves isolated, we can really flatten this curve, we can slow the spread, and we can afford to treat people who need treatment, and that will vastly reduce the death rate. And that's really what we're trying to do, is reduce the fatality rate of this virus by ensuring that there's enough health care to go around when people are sick. So stay home, wash your hands. See you guys online.